the year 2018, and it has been working to some extent. These somebody talked about azithromycin, depending on the weight, 500 to 1,000 milligram on OD basis, but it has to be given for a period of 10 to 14 days. And injectable, where orally either the patient is not hemodynamically stable or is not able to take azithromycin orally, or is allergic to azithromycin, or for some reason, then you go for these. And again, these have to be given for 14 days. Now, this is a dilemma. We are actually, my talk was the second one. The first one was on COVID. Dr. Saab is going to talk about COVID. In COVID, we are giving azithromycin like anything. Um, Especially since the policy of home isolation came, especially to Punjab, patients were advised to take azithromycin. And who was advising? Myself. We ourselves were advising azithromycin to save them from COVID. Now what will happen? Would Till last year we were telling no, chest infection ke liye azithromycin nahi deni. First go for other options. Why? Because we are facing XTR enteric, and we do not want resistance against azithromycin. Now what to do? इसमें तो हमने सोचा ही नहीं, because we wanted to save the lives of the patient. Now what will we do? Iska jawab I leave to the chairs, because I don't know the answer. And perhaps time will give us the answer. And hence, whenever there is a difficulty in the cure or the treatment, which is, alhamdulillah, as yet not so for XTR, the onus of treatment lies on the shoulders of prevention. So prevention, prevention, prevention. वो मक्खी 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 हाथ धोने हैं, वही वो सारे काम करने हैं जो कि अगली 3 स्लाइड्स में मैंने बड़े छोटे 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 करके लिखे हैं. खाना है तो पूरा पका के खाना है. Luckily, the typhoid as well as paratyphoid, they destroy by the boiling within 3 minutes. So अच्छा पका हुआ खाना हो, कच्चा खाना ना हो. आज सुबह जो सैलेड्स इन्होंने खाए हैं वो जरा ध्यान रखें. Hopefully Allah Ta'ala उनको सेहत दे. But be very careful about uncooked food. Another very important thing is the development of vaccine. This vaccine has now been, it's an injectable one-dose, single-dose vaccine, and booster can be given every 3 years. And this has been introduced in the EPI program beyond the age of 2 years. So this is a good vaccine, and it gives prevention in up to 70% of the cases. And who to vaccinate? ये ऊपर वाला तो आप रहने दें क्योंकि हम हैं ही एंडेमिक, लेकिन जो हमारे रिश्तेदार who have been staying there for 20-25 years, when they are coming to Pakistan, we ask them to get themselves vaccinated. Then number 2, persons with intimate exposure to documented carriers, right? So a person who has had a cholecystectomy, and when you send the sample, when the surgeon sent a sample for culture sensitivity of the gallbladder and they found enteric bacillus, all of the contacts need to be vaccinated, right? So remember, this is another thing which we physicians are going to tell them. Please remember, vaccine exists, easily available, injectable is very easily available in Pakistan, and it has to be administered. And then number 3, very important, which includes almost all of us who are in direct contact with enteric patients. So vaccination is important, and military personnel have also been advised to go for. So remember, abhi bell nahi baji, where there is ruin, there's hope for a treasure. ठीक, ये ruin जो है ना, ये COVID की तरफ ज़्यादा जा रहा है. Many of us, our families, our lives, our doctors. Kal there was a video on the inauguration ceremony of all the shuhada of our profession. But there's always a treasure and a light of hope. Thank you very much, but I won't finish here. I still have time. Since I've been a dormant member of Pakistan Society of Internal Medicine, Professor Javed Akram is not sitting here, but there are people here who have special interest in poetry. Professor Tariq, Professor Munir, and Professor Aftab Mohsin, to be specific. This is a piece of poetry I wrote early in the morning, just before Fajr. And this is dedicated to Pakistan Society of Internal Medicine. for being dormant during the last, during, since its creation. I'll read it from there. I promised Hina yesterday night that I'll write poetry. And I told her maybe I'm not able to because I'm so tired. कुछ कर दिया मैंने. A wish come true. I wish I open my fatigued eyes and find myself where the mountains meet the sky, where they seem to reach for the stars, the tip of the pine trees standing tall so high. I wish I was there all alone, with him to console my restless soul, to talk to him in the tranquil quietness as up the deserted track I leisurely stroll. अभी stroll करने का मुझे मौका नहीं मिला, लेकिन इंशाल्लाह मिलेगा. I wish I would eventually discover what I'm trying to eagerly find, the answers to my illimitable queries which keep on lingering in my unsettled mind. I wish I would find out, are you closer to him when alone? But how could that be? He is magnificent, magnificent. He is everywhere. It is well known. I wish, I wish I would really know what I crave to be up there on my own. Sorry, why I crave to be there on my own. This yearning to be at a place where I lose the connection with me of the world to me known. I wish I could explain to all my dears, I have 100 things to ask. From him Almighty, the merciful, I want to go there to fulfill this task. I wish I could convey to them, it is the unadulterated nature where I want to be blown, where his creation seems to watch and talk to you, nobody else but him, yearning to seek it all alone. And I still wish to go up there, where the stars come down at night, and the dearest one I'm searching for reaches to me, assuring everything will be all right. So besides Pakistan Society of Internal Medicine, this is dedicated to my late father, who is the star who's probably trying to search for me and reach out for me down here. Thank you so much. And there's another thing, probably I have it here. This is something, abhi puri nahi hui, but this was something I tried to. Puri raat jaagi nahi hu, you know, thank you so much.
Thank you so much, Professor Shabir, the Senior Vice President of Pakistan Society of Internal Medicine, and the person who has taught me how to walk in the corridors of medicine. Thank you so much, ma'am, for giving us an insight of your creative part of the personality. Now, before moving on to our next talk of the day, for all of you, there is a little information. Our sessions are going live on our YouTube channel by the name of PSIM Midsummer 2020 Azad Kashmir, Muzzafrabad. So those who are not over here, or your friends or family who are unable to make up to the Pearl Continental today, they can have our sessions on the YouTube channel. Talking about the COVID-19, a pandemic which has changed our lives in so many ways, or I must say which has reshaped our lives back to some old era as well. We have seen so much diversity about the COVID-19, a virus which is also known as novel virus. To have talk on COVID-19, I would like to have Professor Abdul Halik Awan. He will cover the experiences in the COVID-19. I'm sure we all are well aware of about the basic concepts of COVID-19. To have some experience talk over it, I would like to have Professor Abdul Halik. Sir, please.
Bismillah. Thank you, Madam Chair, respected, especially where now in Pakistan, everybody is expert on COVID and everybody has discovered, especially the Pakistanis have discovered a wide range of treatment for this COVID, and from onion, from kalwanji, and from garlic, and sona makki and whatnot. We have discovered in over a period of 5, 6 months a wide range of treatments for this disease. As I was dealing with these patients, and I was compelled to take a small spoon of kalwanji and garlic in the morning with lukewarm water uh, for treatment of COVID-19 at my home. But today we will talk about some hard scientific facts about this. And this is the disease which is caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, COVID-19, which has changed the financial, political, social, and economic structure of this world. And this is how we are living now with this virus, and we have to live with it for quite some time. And these are the timelines of this virus. On December 31st, 2019, it was reported to WHO, and it was declared as global health emergency on January 30, 2020, and global pandemic on March 2020. How we get out of this disease? And these are the words from Dr. Jeremy Farrar. The only way the world can exit this pandemic, we need diagnostics to detect and limit the spread of the virus, vaccines to provide long-term protection, treatments to save lives in shorter term, and social science to understand the behavioral and social implications. A lot of work we have done over here. We are much better at diagnostics of this disease, and a significant progress is over here as well. Vaccines and social sciences and behaviors, as we are sitting over here, there's a lot of change over here as well. Uh, we are lacking over here the basic topic which I am supposed to talk about it. We don't have much over here. All the treatment which is available is basically the treatment which is repurposed. The drugs which are used for treatment of this disease at the moment are repurposed based on their previous experience of antiviral activity, anti-inflammatory properties, and immune modulating effect of these drugs. So we repurpose those drugs for treatment of this virus. What are the clinical presentations of COVID-19? We know it that it ranges from asymptomatic to mild symptomatic to severe disease and sometimes mortality after critical illness. And symptoms may develop in 2 days to 2 weeks following the exposure of the virus, and mean incubation period is 5 days. 97% patients develop symptoms within 11 to 12 days after exposure of the virus. The coronavirus is a vast family of viruses, and this virus is, which is now responsible for COVID-19, has similarity with the virus which was detected in the bats some 100 kilometers away from Wuhan. And just 7 are known to cause illness in human beings. And some virus typically infect animals, and then they evolve to infect human beings. And perhaps same is happened to this novel coronavirus too as well. And this is the structure of the virus. This is the special glycoproteins which stick to the human cells and facilitate the entry of this virus into the human cell. Membrane proteins and nucleoproteins. This is the structure of this virus. Uh, as far as the severity of disease is concerned, the 72,000 patients which are initially reported to Center for Disease Control and Prevention in China, 80% were mild disease, absent or mild symptoms, 13% were severe, 5% were critical, and 2.7% was the mortality rate. In HAK, as per yesterday, official statistics are that there are 2,305 patients, and mortality in these patients was 64, and the mortality rate in AJK is 2.7%. So it is almost with the international standards. So what are the symptoms? Cough and shortness of breath, plus at least two of the following symptoms may indicate COVID-19: fever, chills, repeated shaking chills, muscle pains, headache, sore throat, new loss of taste and smell. Most of these symptoms are similar with any infectious illness, especially prevalent in our setup, malaria and enteric and respiratory tract infections. So there's nothing specific except for if there is loss of taste and sudden abrupt onset of fever along with myalgias. Other reported symptoms are fatigue and sputum production, diarrhea, malaise, and respiratory distress. The most common and serious complication is involvement of the respiratory system in this. Most common symptoms, again, fever and cough, and less common is sore throat and shortness of breath and fatigue and aches and headache, runny nose and diarrhea is a rare symptom. But in number of our patients, we have seen diarrhea quite prevalent in our setup. These symptoms are uncommon in children, and these can present as Kawasaki disease and toxic shock syndrome, but symptoms are less prominent in children. How we classify this disease clinically: if a patient with COVID-19, suspected COVID-19 or confirmed COVID-19, if comes to my unit, how I am going to classify that this patient will fall in this category. So the one is the asymptomatic patients when there are no symptoms, obviously. What is the mild disease? In which there is oxygen saturation of more than 94%. There is no hemodynamic compromise. There's no need for oxygen, and there is no abnormality on chest X-ray. So this is a mild disease. And 81% of patients fall in this category. Moderate disease, when there's oxygen saturation of less than 94%, but it is more than 90%, and chest X-ray infiltrates less than 50% of the lung fields. And what is the severe disease, especially in adults? Clinical signs of pneumonia, fever and cough, plus any one of the following: a respiratory rate of more than 30, severe respiratory distress, oxygen saturation less than 90%, and chest X-ray involving more than 50% of the lung fields will categorize it as severe disease. And then the fourth form is the critical illness, in which there is either ARDS, whether there is multi-organ dysfunction, or patient is suffering from septic shock. Then we label these patients as suffering from critical illness. It is here where we found most of the mortality in these patients. What is ARDS? It is the onset within 1 week of the symptoms onset, and just imaging on just X-ray or CT scan, there's bilateral opacities, not fully expanded by volume overload, lobar or lung collapse, or nodules. There's no other explanation of radiological abnormalities in these patients. And origin of pulmonary infiltrates, respiratory failure, not fully expanded by cardiac failure or fluid overload. So opacities on the radiology and the failure could not be expanded on the basis of any other respiratory or cardiac disease. This is ARDS and oxygen impairment in adults. Multi-organ dysfunction, a life-threatening organ dysfunction caused by dysregulated host response, where there are signs of organ dysfunction, altered mental status, difficulty of fast breathing, hypoxemia, reduced urine output, and shock, tachycardia, weak pulse, cold extremities, and hypotension, and skin mottling, and there is lab evidence of multi-organ failure. This is classified as multi-organ dysfunction. And then there is septic shock when there's persistent hypotension, which is resistant to all available therapies. So, or if serum lactate level is more than 2 millimole. What is the management? How we are going to manage these patients? There's a lot of controversies about the management of this disease. And as Dr. Saab was saying, that we have used whatever seemed to be beneficial based on anecdotal evidence and a little bit of experience, some initial studies in a small number of patients. Whatever is coming from those studies, we use to start their treatment. And that heat was further ignited by the President Trump when he said that perhaps the cure is there in the form of hydroxychloroquine. And President Trump was using for this hydroxychloroquine for the treatment of COVID. Mild cases can be managed at home with home isolation criteria, and the criteria is patient must have a separate room to stay with a separate washroom, and he is consenting for the isolation as well. Mild disease doesn't need any specific treatment, and those patients who are having these conditions can be considered for admission and observation if they are immunocompromised and if there are comorbid conditions in the form of heart failure, decompensated liver disease, structural lung disease, uncontrolled diabetes, and chronic kidney disease. Moderate and severe critical illness, all these three categories must be admitted in the hospital. And if patient is suffering from moderate disease, he can be admitted in a well-ventilated general ward. If it is severe disease, then high dependency unit with negative pressure and critical illness in ICU with negative pressure. And we know what are the parameters for categorizing these patients into the different categories, clinical categories. And in all these facilities, oxygen and pulse oximetry is mandatory. Management, is there any for mild disease? Can we use prophylaxis? No role of prophylactic chloroquine or hydroxychloroquine at this time. So we must be very clear at the moment that hydroxychloroquine, which was used as the mainstay of treatment, doctor was using, and we in medical units initially used hydroxychloroquine along with azithromycin as the first line treatment for these patients for a significant prolonged period of time. We have been using these drugs, but now hydroxychloroquine in all trials in the world, a solidarity trial and the trials which are ongoing in the USA, recovery trial, from every trial, this drug hydroxychloroquine has been omitted. So there's no role of hydroxychloroquine, and same for antibiotics as well. And side effects, obviously, of this drug are observed. And sporticure, acetaminophen, oral hydration, severe cases of diarrhea, and antihistamines, no specific treatment. Azithromycin, ivermectin, famotidine, which have shown, for example, famotidine has shown better recovery in patients who are taking this drug as compared with PPIs. Ivermectin has a significant antiviral activity in vitro, but whether we can get in patients those concentrations is controversial, and azithromycin should not be used. So no hydroxychloroquine, no azithromycin, no ivermectin, no famotidine. This prophylaxis is not recommended as we, and all these, this is now with, I'm talking about our national guidelines as well. This is from our national guidelines. And management of moderate, severe, and critical illness. Moderate disease, obviously, supportive care, and all patients must be assessed for cytokine release syndrome, CRS, with following investigations: blood CPC, ferritin, C-reactive proteins, lactic dehydrogenase, D-dimers, chest X-ray, and optional investigations are LFTs, renal function test, blood cultures, BSR, and for severe and critical illness, ABGs and serum lactate and respiratory cultures are required. Optional investigations include procalcitonin, troponin, echo, pro-BNP, IL-6, and CT scan of the chest. Specific therapy, Sporticure. The mainstay of management for COVID-19 is oxygen therapy via nasal cannulae or face mask. This is the mainstay of treatment. We must remember that anything which we have specific for COVID-19, which has benefited the patient, this is the treatment which all patients must receive. All patients with low saturations should be placed in prone positioning. This is one thing which most of the time we forget. These patients are much comfortable and oxygen saturation improves. I don't know how many of you have the experience of treating these patients, but all those patients in which oxygen saturation is persistently below 90, when we prone these patients, you get the immediate rise in the oxygen saturations in these patients. And for those not intubated, voluntary awake prone positioning should be encouraged for as long as patients can manage. Although it's a little bit discomfort for the patients, but this is the thing which we need to do in these patients. For patients on ventilators, 12 to 15 hours of prone positioning should be attempted. It is a very challenging sort of thing in these patients with intubated and making these patients prone. It's very difficult. Technically, it is very difficult, and especially when these patients are managed by physicians, not their sort of intensivists, then we have a lot of problem by doing prone positioning in these patients. Steroids, all patients on oxygen should be given steroids, dexamethasone or methylprednisolone. Dexamethasone has more potent glucocorticoid or anti-inflammatory activity, while methylprednisolone is superior as in mineralocorticoid activity, or somebody is suffering from shock, then we may go for methylprednisolone. So 5 days treatment, it can be prolonged if there is persistent hypoxia, and dose is 6 milligram per day of dexamethasone, oral or intravenous, and for methylprednisolone, zero point 0.1 to 1 milligram per kg per day. The other treatment, along with oxygen and steroids, now the standard treatment is anticoagulation. As these patients are, it is the tipping of the coagulation in a person who is having, for example, in dengue, it is tipped towards bleeding, and in COVID, it is tipped towards hypercoagulation. So we need to deal this, and there's number of options for these patients. If patient is already on anticoagulation, we can continue the same dose. If patient is severe or critically ill, we can switch over to parenteral therapy. Those patients who are not anticoagulated, we can use enoxaparin. This is what we are using in our setup, 40 milligram once daily for prophylaxis. For severe disease, aggressive prophylaxis with enoxaparin 40 milligram every 12 hourly. These are the doses in patients who are not having any evidence of thromboembolism. If patient has evidence of thromboembolism, then documented presence of thromboembolic disease, then or there is strong suspicion in those patients where we cannot investigate, we cannot do investigations, then this is or D-dimers are 3 times upper limit of normal, enoxaparin 1 milligram per kg every 12 hourly, and switch over to rivaroxaban on discharge, and it should be continued again as we do it in DVT. It is recommended that it should be continued for 3 months. The dose adjustments of enoxaparin in renal disease, we have with us a renal unit as well. So this is the frequent problem over there. So we should know how we are going to adjust doses in renal failure. If creatinine clearance is more than 30 ml per minute, then 40 milligram OD or BD. Between 15 and 30 milligram OD or BD. And if it is less than 15, we are not using enoxaparin. Unfractionated heparin should be used. And for same is for those patients who are suffering from who are having dialysis. The next drug, which has shown benefit in COVID-19, is remdesivir. Indications for this, these are the, again, national guidelines for remdesivir. Moderate and severe COVID-19 requiring oxygen therapy, regardless if CRS is present or not. And this can be given in critical COVID patients, but the benefit in critical COVID patients is undocumented. And the dose is 200 milligram IV on day 1, followed by 100 milligram IV daily on day 2 to 5. This is now, we are unlucky that we don't have this drug with us. This is now manufactured in India, and the price of one vial 100 milligram is just 1,000 rupees. So for 5 days treatment is just the 6,000 rupees, and it has shown number of studies that this drug is beneficial. But we don't know why there was a this Feroz Sons was supposed to come up with this drug, and Sirlis supposed to come up with this drug, but unluckily, I don't know what is the reason, but still we are looking for this drug in our patients. This is remdesivir, which has shown benefits. This drug is basically, again, a repurposed drug for COVID-19. It is the drug which was developed for Ebola virus infection, and it inhibits replication of human coronavirus. It was effective in SARS-CoV in 2003 and MERS-CoV in 2012. And it has shown efficacy against coronaviruses in all animal models. So it's shedding of the virus, and it has antiviral activity in all animal models. So this is the trial in which 1,036 patients showed that remdesivir accelerates recovery in patients who have been given remdesivir. Patients on remdesivir had 31% faster time to recovery than those who received placebo. The median time to recovery was 11 days with remdesivir as compared with 15 days in those who received placebo. This was the strong evidence for the use of this drug. And there was survival benefit as well. The mortality in this group was 8% as compared with 1.6% in those who were using placebo, but this was not statistically significant. We are left with one or two. Stop. Okay. Uh, This is a recovery trial, which have shown this benefit. Then there's a simple trial in which is 5 to 10 days treatment compared in those two groups of patients. Remdesivir was used for 5 days and 10 days, and the results were same. We can use it for 5 days instead of 10 days. And Faviprevir is the other antiviral. It is again available in India. It's again the drug which reduces the illness by 50%. Duration of illness is reduced by 50%. It is from Japan, and it selectively inhibits the RNA polymerase virus, and it is well of other countries. Unluckily, we are still looking for this drug to be available. Therapy for cytokine release syndrome. These are different parameters for categorization of these patients as they are suffering from CRS. And then there is tocilizumab. This is the drug again, which has shown benefit in especially in those patients who are at high risk of developing CRS. I will not go into the details of these studies. Uh, uh, the only problem is that this drug again was not available to a very high profile minister in Pakistan. This is how we are previously. Atemra was available freely, but with this pandemic, this drug vanished from the market. But this is the drug which we have used in those patients who are having markers for CRS. And number of contraindications and dose adjustments for this drug. But as we are running short of time, convalescent plasma just recently approved by FDA to be used, and there's parameters for antibody titers in the patients from whom this can be taken. And perhaps we are not having those parameters. No role of prophylactic antibiotics, but those patients who are having infections, antibiotics should be used in these patients. And these are the recommendations for discontinuation of the isolation. The virus will keep on shedding in some patients, but that shedding of virus doesn't mean that these patients are infectious. After resolution of symptoms, 10 days from the start of symptoms or 3 days after the resolution of symptoms, all patients can discontinue isolation. There's no need of retest in these patients. In those patients who are immunocompromised and those who are living in jails and dorms and healthcare workers who take care of immunocompromised patients, we need retesting in those patients. These are the few trials which for this solidarity trial, recovery trial, and these are the few trials which are landmark trials in this condition. I have taken a little more time. Thank you very much. If there are any questions, I will be there at the end of it. Thank you very much.
Thank you so much, Dr. Khalid Aman, for such an informative talk on COVID-19. Sir is currently serving at Jammu Kashmir Medical College. Okay. Moving on to our next talk of today, we have talked about dengue, we have talked about COVID-19, we have talked about XDR, enteric fever, but we haven't talked about tuberculosis therapy so far. TB is a disease which has covered a large population of our part of the world and which has affected more than 1.8 million population throughout the world. So to have a talk on tuberculosis and anti-tuberculosis therapy, I would like to have Dr. Suhail Raja, who is the consultant pulmonologist and who is an intensivist and sleep specialist. And he is a fellow at American College of Chest Physicians and also a fellow at a European Society of Intensive Care Medicine. Sir, I would like to have you on the stage. Dr. Suhail Raja.
Thanks for the nice introduction. I would like to welcome all the distinguished guests and all my colleagues here. Uh, Tuberculosis, and especially the MDR tuberculosis, is one of the that segments of our education. Being a fellow, I did my FCPS in respiratory medicine. It was always a difficult field to manage, especially the MDR patients. And over the last few years, there is this continuous changing of the guidelines. So we are a bit behind timeline. So I'll try to summarize it for you. Just I'll ask an interactive question. How many of you have prescribed the MDR regime? Any of my colleagues? MDR regime. So after the advent of PMDT sites like this National Tuberculosis Program, this program is like now a bit sidelined from the main. So I will try to make it simple for you. As Madam Balkis said, we are facing a crisis of antibiotic resistance in Pakistan. Same is with the tuberculosis. I'll start my presentation. First of all, I'll just another linked thing. There is, due to COVID, the focus is now on the modes of transmission that was lacking. And we used to proudly say that tuberculosis is a national disease, which is, I think, not a thing to be proud of. Tuberculosis mainly by the airborne infection. Like same now, all of us know that there are three modes of transmission of infectious diseases, like contact transmission, then droplet transmission, and then is the airborne transmission. And this tuberculosis is the airborne transmission. It's also an epidemic, and this has been cleared from the West by simply following the infection control guidelines. They have used the negative pressure rooms. They have isolated the patients, and there's no tuberculosis there. But unfortunately, I hope that now the focus is on these like more scientific, like tuberculosis. Believe me, COVID has killed 6,500 Pakistanis. In the same time, tuberculosis has killed 20,000 Pakistanis. But no one is bothered. I don't know the socio-economic strata or whatever the reasons, but it could have been eradicated much earlier. So coming to the point, the estimated incidence is like 500,000. This is estimated. And reported cases, like they are 370. And deaths is 43,000 Pakistanis die of tuberculosis every year, which makes about like 6,000, like 12 into 4, 3 or 4,000 per month. So this is something very crucial which should be focusing. And there is a global emergency declared. There are two programs. National Tuberculosis Program, NTP, is running this highly integrated system to eradicate this condition. There is NTB program. These two the organizations are working very closely over this matter. My topic is, all of you have used the first line tuberculosis, and you keep on prescribing because there's such a big burden of the patients. My special focus will be the multi-drug resistance. Multi-drug resistance, I remember in my fellowship that 2 years of 8 or 10 drugs with IV 6 or 8 months, it was for the patient, it was very difficult to take. And for the doctors to monitor the adverse effects, these things were like very much difficult to manage. But the two things have revolutionized the MDR management over the last decade. One is Gene Expert, RIF-assay, and the second is LPA, Lion Probe Assay. These two are basically rapid detection. There's DNA-based polymerase chain reaction tests, which detect the resistance to rifampicin and later on to the resistance to the second-line drugs. So it's not that boring anymore. I feel like this is a bit exciting. You get which drugs are susceptible, so you start with them. So we'll be focusing on the regimens used in the MDR tuberculosis. So this is the burden, disease burden. 562,000 patients, there is estimated prevalence in Pakistan, and 43,000 mortality is there. But you see the line on the bottom, if we can use this point. Any you can do it without pointer. Okay, leave it. We'll manage without the pointer. Yes. ठीक. So this was the incident of the drug sensitive TB, and you see the trend is going upwards. The case detection, case reporting is improving day by day, and treatment success rate in drug sensitive TB tuberculosis is 93%. The, the 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 point of discussion today is drug resistant tuberculosis, and there is a primary drug resistant tuberculosis. The patient who haven't even taken the drugs first line before, they can have, there is chances that 4% of them can have resistance MDR at the presentation. In the retreatment cases, there's 16% chances they are having MDR tuberculosis. So in last year, we had about 4,000 MDR cases in Pakistan, and 95 they are XDR. And out of the 3,800, 3,100 they were treated with the treatment success rate is 64%. But you see on the right side, this treatment success in the XDR is just 35%. Over the last decade, there is a PMDT treatment, this programmatic management of drug-resistant tuberculosis. This is an integrated program. You can see there are 33 centers. They are scattered all over the Pakistan. They have installed the gene expert devices over there, and there is also an expert person who is capable of managing the drug-resistant tuberculosis. And if you can see closely at the bottom, there is 33. There is AIMS, which is our hospital in Kashmir. It's also part of that. As the focus is increasing on the tuberculosis, you just see these are the booklets which have been published by the WHO frequently over the last 24 years, and the frequency is increasing day by day. I'll make things simple for you, not to be much complicated. There is a consolidated guidelines in 2019, which you see there is 3 regroupings have been done in last 7 years. So that they keep on changing, shuffling the drugs according to the new data. So there is a new classification of drugs, and there is a composition of longer MDR treatment regimes. There are 2 options if you have an MDR patient. One is to do the STR, shorter term regime. That comprises of just 11 months, but there is specific criteria for the patient to be eligible for that. There is another which is LTR, long-term regime. There are 4 different regimes in that. I'll not bore you with those details, but I'll just give you a comprehensive details. And there is a recommendation of against the use of kanamycin and captomycin. These 2 drugs are out of MDR treatment. And what are the minimal changes? The duration is like same, 18 months to 20 months. Use of shorter of MDR regime. There is a change. I'll let you know what is the change in the short MDR regime. And the use of culture and microscopy is almost the same. There should be monthly smear plus cultures. And there's no change antiretroviral with the patient with HIV. Use of surgery, localized disease you can do. Go ahead for the lobectomy or segmentectomy along with the MDR treatment. And then there is guidelines for the INH resistant tuberculosis, which is a bit different, and patient care and support. So there are basically 2 sort of regimes, longer and shorter. Longer comprises of about 20 months, 18 to 20 months, and shorter is 11 months. And then there is culture monitoring. Then these are actually the highlights of my presentation. INH resistant tuberculosis, we found it that intrinsically our Pakistani population, about 15% of them, they are resistant to INH. So we should be doing the INH resistance at the baseline as well. Surgery and the model of care. Just this slide is basically the crux of this presentation. These are the regrouping of the MDR medications. If you see the group A comprises of levo or moxi and bedaquiline. Bedaquiline is the anti-tuberculosis drug recently introduced, and linezolid. We are using it linezolid in the ICUs like IV, but this is oral. The WHO has realized that IV drugs are very difficult to manage, especially in resource-limited areas. Daily IV injections is difficult. So what they did, they have tailored this regime This is without IV injections. So there is just oral treatment. Uh, the group B comprises of clofazimine and cycloserine and terazidone. In longer treatment regimes, you have to structure your treatment from these two groups. So what you do, you take three drugs from the group A, levo or moxi, and bedaquiline and linezolid. And then what do? You add two drugs from group B, clofazimine and cycloserine. So these are the five effective drugs which are to be used, and the bedaquiline is usually stopped, and linezolid is usually stopped after the 8 months. And the group C drugs, they're usually add-on drugs. If we are unable to like formulate a regimen from group 1 and 2, then we can add from the group C. So longer MDR regimen is 18 to 20 months. Time after conversion, like if the patient is sputum negative and culture is negative, after that there should be at least 15 months treatment. And the injectable phase, there are four long-term regimens. LTR 3 and 4, they contain IV. LTR 1 and 2, they do not contain the IV injectable phases. So shorter MDR. Shorter MDR regimen, actually, there is not much like meta-analysis behind this. There are observational studies, and this study was done in Bangladesh, and with a treatment success rate of 68%. But there is a criteria, the patients who will qualify for this shorter MDR regimens. The one is like patient should not be treated with like quinolones or linezolid for more than 1 month, and there should not be extensive disease or extrapulmonary disease like meningitis. Now, there is this update is incorporated in 2019. Previously, we used to write and tell the patient, okay, this is your medicine. Okay, take this. But now we give the patient the choice. You have 2 years choice. The other choice is 11 months, whatever you want to take. Obviously, patients, they tend to take the shorter regimen. And there should be active drug safety monitoring for the patients who are on the MDR. Culture should be monthly culture, spear microscopy, and there should be how the care and support. The countries who have been able to eradicate the tuberculosis, what they did, they isolated the index case and kept in the hospital till they are negative in sputum and cultures. And then they send into the community. But that obviously, and you have to keep these patients in negative pressure room. Negative pressure room is quite like a complicated thing. And I don't, in Kashmir, we don't have a single negative pressure room till now. And even in Pakistan, in the best of hospitals, there are limited, a very limited number of negative pressure rooms. So what we do is community or home-based treatment, but these patients should be wearing masks at home if you send them home. And there is DOTS program, which is directly observed, or there is video observed treatment. You can observe the patient with the video, and health education counseling and treatment adherence. You have to keep motivating the patient that you have to adhere with this medication. Otherwise, MDR has a success rate of 60%, but the XDR has a success rate of less than 30%. So the options are less. In 2019 December, the WHO issued this advisory. The shorter regimen included the amikacin. What they have now suggested that even in the shorter regimen, the amikacin should be replaced with the bedaquiline, and the all other medication should be like the same. And the patients, the criteria is the same. The patient who haven't used these fluoroquinolones and this linezolid, they are eligible and they don't have the extensive disease. The models of care, you don't need to admit the patient like the bound. It should not be bed bound. Patient can be ambulatory in the hospital or at the home, and decentralized model is recommended. So conclusion is that now you have much more options in your MDR and XDR. You can refer your patients. All of you are coming, most of you are coming from the teaching hospitals. There should be a PMDT site in your hospital or nearby. You can refer the patient with the suspected or presumptive drug resistant tuberculosis to them, and observation for the severe drug reactions. That's my, I have detailed regimens with me. I didn't want to make things complicated for you, I can share with you who are interested in person. Just few things just to add on to the Madam Balki's points. Being a pulmonologist, we come across the patient with upper respiratory tract and lower respiratory tract patient. Two-thirds of the world's antibiotic consumption is on these two upper and lower respiratory tract conditions. And believe me, 70% of them are viral. So what we are doing? We are giving unnecessary antibiotics. Human body contains 33 trillion cells, and human body contains 300 trillion microbes, and these microbes are there for some purpose. Okay, they are part of our homeostasis in physiology. Then what happens? Okay, in the Pakistan, you can take the antibiotic over the counters. You take antibiotic, quinolones. Quinolones, when it was like developed, $130 billion were spent on developing this drug. And how we are using in Pakistan? We are starting with batrifloxacin, moxifloxacin, and believe me, madam is saying that azithromycin should be preserved. The drugs should be preserved. I have senior faculty members, like they have links in the power corridors. There is a draft. My strong recommendations will be the ban antibiotic from over the counter. Please. This. We are facing a crisis in Pakistan. Superbugs are emerging. Superbugs are emerging. Being an intensivist, I see like hospital-acquired pneumonias. They're XCR, they're TDR, they're total drug resistance. What we are doing, and the people who develop antibiotic, they're not no more interested. There is not a single antibiotic group is added to the list since 1998. Why? Their infections are under control. They are working on molecular medicine. They are targeting immunotherapy. They are targeting like the investment, the big pharma. They are investing on the things which give them return. What we are doing, we are just consumers. We have utilized all of our antibiotics. For God's sake, please, you are like my junior doctors, my colleagues. Fever is not a sign of antibiotic deficiency. Make protocols, get the cultures from your community. If it is difficult, at least in the hospital, there should be antibiogram, the yearly antibiogram, which tells you which antibiotics to use, which organisms are prevalent in the hospital. Like being a consultant doesn't mean you have right to do anything. There should be integrated team with the microbiologist. If you want to give an antibiotic, there should be some rationale behind it. So just I'll conclude with my remarks. Please, this antibiotics, be very cautious. Be very cautious, and there should be a campaign that these drugs should not be available over the counter. That's my submission. Thank you for listening.
Thank you so much, Dr. Suhail Raja. He's very right in saying there are no new drugs, but every day we are seeing the different spectrum of disease resistance and sensitivity. To have a look into such matter, I would like to have Mir Ibrahim Sajid over here, who is a fourth year MBBS student at Aga Khan Medical University with a special interest in the field of research involving public health and infectious diseases with more than 15 national and international papers. I would like to have Mir Ibrahim Sajid on the stage, please.
Right. Assalamu alaikum. Assalamu alaikum. My name is Ibrahim Sajid. I'm a fourth year medical student at the Aga Khan University. And I'll be presenting on a very important topic, carbapenem sensitivity versus resistance. And we're looking at the impact it has on clinical outcomes during hospital stay. Now, I would like to tell you that this is a preliminary finding of an ongoing study, and it has been accepted for publication in the Central European Journal of Medicine. And the study is being continued at the Aga Khan University Hospital, and we have more than 300 patients recruited. But for the sake of this study, we're going to have a sample of 50 patients, and we're going to look at their clinical outcomes and prognosis. So, carbapenems for a very long time have had our backs, and they've been the wonder drugs. And they've been wonder drugs because they possess the broadest spectrum of antimicrobial activity, especially against gram-negative rods and gram-positive cocci. Now, and that's because they're relatively resistant to hydrolysis by bacteria, and so they form one of the most important antibiotic of your antibiotic armory. How they work is that carbapenems, they enter the bacteria, especially the gram-negative rods, through outer membrane proteins called the porins. So porins basically act as channels for the antibiotic to enter the bacterial cell. Once they enter the bacterial cell, they permanently acylate the penicillin binding proteins. Now, the penicillin binding proteins, as we all know, they help in 3D configuration and dynamic stability of the bacterial cell wall. Now, the bacterial cell wall, which is technically undergoing remodification, breaking down and remake of the cell wall continuously, it requires penicillin binding proteins to ensure that it has a strong dynamic cell wall, providing it osmotic resistance in different environments. Now, once the penicillin binding proteins are acylated, it cannot confer any more strong dynamic 3D stability to the bacterial cell wall, rendering it more susceptible to autolysis in the different osmotic gradients. The primary concern today, as my colleagues have mentioned earlier, is antimicrobial resistance, and it is on the high. Um, in terms of carbapenems, more than 60% of non-fermenters have shown resistance to carbapenems. And when I'm talking about non-fermenters, I'm talking about organisms such as Acinetobacter, Lactobacillus, and Pseudomonas aeruginosa. And only less than 10% of the non-fermenters have shown resistance to carbapenems. And among non-fermenters, among fermenters, we have Lactobacillus and Streptococcus. Now, when we talk about mechanism of resistance, and I'm going to skip the gram-positive coccysteine, I'm going to stick onto the gram-negative rods. When discussing gram-negative rod infection and resistance, we see that gram-negative rods, they express beta-lactamases. What it does is it produces the beta-lactamases, which break down the beta-lactam rings in the antibiotic, which technically renders the antibiotic useless for bacterial invasion and control. Secondly, what it does, it produces efflux pumps. So whatever antibiotic it enters the bacterial cells through the porins, what it does, it actively pumps the antibiotic out. So it does not have time to work with the penicillin binding proteins and change the configuration or acylate them. The third thing that they do is that they close off the porins. They lose their outer membrane proteins. They lose the channels which allow the entry of the antibiotic in the bacterial cell. So no gates, no entry, which makes them more stronger to antimicrobial activity. And the fourth is the alteration of the penicillin binding proteins. When you permanently change the amino acid sequence of the penicillin binding proteins, what you basically do is you make the antibiotic in an open space where it does not recognize its host anymore. So when it does not recognize its target, the antibiotic, even if it enters the cell, it does not know where to act. And so it does not act. That's the reason that they have this resistance to carbapenems. Now, antimicrobial resistance have statistics which change from all over the world. We have different antimicrobial activities from different regions of the world. We have different activities in the United States. We have different rates of resistance in Europe and so in Asia. However, studies from Pakistan are very limited, and that is the primary objective of the study is to compare the clinical impact the carbapenem resistance has on inpatient clinical outcomes. And so what we do here is we primarily look at the patient outcomes. We look at how, if they develop any complications during their stay at the hospital, and what are the outcomes, what's the prognosis. And then we evaluate the spectrum of antibiotic sensitivity in both these cohorts. It's a retrospective cohort study. We include patients from January 2015 all the way to December 2018. That's the data we have as of now. We use the ICD codes, which basically allude to gram-negative sepsis, inpatient hospital stay, and carbapenems. So we include patients, all the patients who were admitted at our center at the Aga Khan University Hospital with a gram-negative infection, and they had their antibiotic sensitivity testing done at our center. And that is basically just to ensure that we have uniformity of results and do not have heterogeneity. Data was collected on a structured pro forma, and we recorded variables such as the initial clinical presentation, the chief diagnosis, the outcomes of the patient, and then the results of the antibiotic sensitivity. The data was then analyzed using IPM SPSS version 21. And for the sake of the presentation, we are just showing univariate and bivariate analysis just to make sure that we have numbers to underscore the importance of antimicrobial resistance. So we took 50 patients for this study, and we divided them into two groups. I would like to have your attention on understanding which the two groups are, because in the future presentation, I will be alluding to either GA, which is patients who were resistant to carbapenems, or GB, patients who had a gram-negative sepsis sensitive to carbapenems. And there were 19 in number. So GA is resistance, 31, and GB, sensitive to carbapenems, and 19 in number. In terms of sexual distribution, we have males forming the bigger cohort in both the segments. In terms of age distribution, you'll see that GA is shown in the lighter bars, and you see that gram-negative sepsis resistance to carbapenems is higher in patients who are younger. So we see a prevalent around 20, 23% of GA patients in less than 40%, and only 10% of the patients younger than 40 years old developing resistance to carbapenems. And then we see how the bar chart increases over the age. We see how GA starts increasing, and so does GB, but probably the higher increase in GA is more prevalent in higher age groups. In terms of comorbidities, nothing significant to report here. We have a fair mixture of diabetes, hypertension, ischemic heart disease, and renal function dysfunction. And in terms of presenting complaint, now, I'd like to have your attention on two things. You'll see that GA was more prevalent and more common in pulmonary diseases and pulmonary investigations. However, GB, the sensitive one, was more prevalent in genitourinary diseases. And I'll want you to understand this and keep this in mind, that GB was more important in genitourinary and GA was more important in pulmonary. And again, in terms of genitourinary complaints, we had probable diagnosis of pyelonephritis, ureter sepsis, and recurrent urinary tract infections. And we talked about pulmonary disease, we have pneumonia, pleural effusion, and exacerbation of pre-existing COPD. In terms of source culture, as I was alluding to, because GA was more common in pulmonary infections, we see that the source of culture was more important in tracheal aspirates in blood. And then you see in patients in GB who had primarily genitourinary infection, they have more source of cultures in urine. In terms of organism cultured, E. coli formed the major cohort in both of these groups. We see around 85% of organisms as E. coli being diagnosed on culture in GB and approximately 35% in GA. However, you also note that GA was more common in the non-fermenter bacteria, as we were discussing, such as Klebsiella pneumoniae, Pseudomonas, Acinetobacter, and Enterobacter. Now, the most important clinical slide I want your attention towards here. In terms of hospital stay, patients who have resistance to carbapenems, they have a longer hospital stay. If you see patients in GB first, patients in GB who were sensitive to carbapenems, they had almost 53% of them had a clinical stay of less than 5 days in the hospital. However, patients in GA who had a clinical stay at the hospital of greater than 11 days were 65%. So 65% of the patients in GA had a hospital stay of greater than 11 days. And we all know what a greater hospital stay means. It means more exposure to nosocomial infections, a larger medical bill, and worsening of the medical conditions you have, because you're more prone to developing infections when you're in ICUs as compared to general wards. Now, in terms of complications developed, here's an interesting number. When you see GB sensitivity cohort, we see that there's a fair mix 1-1 to develop a complication. However, when you see GA, patients who develop a complications form a majority of cohort, 77%. And if you take p-value of significance as less than 0.05, we're reporting a p-value of 0.029. We're reporting significant, clinically significant, statistically significant results. So a patient who has carbapenem resistance, they're technically more prone to developing complications. Now, when we look at complications, we see that there are various systems which were involved now. Remember, I was talking how genitourinary complaints were more common in GB as compared to GA. Look at the urinary complications developed among GA patients. All of the patients who developed urinary complications were in the GA cohort. And that alludes basically to the fact that you have a longer hospital stay, you're predisposing yourself to nosocomial infection and catheter-related infections. And so if you have catheter-related infection, you're probably developing a urinary tract infections, and those two recurrent UTIs. And so patients who primarily presented with genitourinary complaints in GA, only 11% of them developed a complication in the same system. The rest of 89% of the patients were those who did not have a presenting complaint related to the genitourinary infection, tract infection. Now, these complications, they included acute kidney injury, pyelonephritis, and a declining renal function. And then if we talk about other systems, we see that in terms of cardiovascular system, the most predominant complication were AFib, VTEC. And in pulmonary infections, we had respiratory failure, aspiration pneumonia, neurological complication, we had tonic-clonic seizures. And in hemodynamic stability, we had declining hemoglobin levels forming the major chunk of the complication developed. Now, in terms of condition on discharge, we see that patients in GB, most of them recover well. 70% of them recovered well during their hospital stay as compared to only 48% in GA. Now, you don't need scientific numbers to see here or regression models to see what impact carbapenem resistance has. It's technically twice the rate of mortality. You see in GB, you have 20% mortality. However, in resistance cohort, you report almost 40% of patient mortality during hospital stay. And that is a big concern. All right, the big slide. This is technically what everyone, all of my colleagues before are we talking about, the antibiotic sensitivity and resistance. And we see, so basically, this Manhattan skyline, the darker bars, they allude to resistance, and the lighter bars, they allude to sensitivity. So in GA, we almost have all of them as darker bars. You see 100%, almost 100% resistance to amoxicillin, ampicillin, aztreonam, imipenem, tiozopiper, ceftriaxone, cefuroxime, cefixime, cipro, meropenem. Almost 100% resistance to all of these antibiotics. And the only sensitive antibiotic in this cohort is colistin. And that I'll tell you in a moment, how that is also not the most perhaps important thing. And then you see GB, the picture isn't good either. You see rising antibiotic resistance in all these, among all these antibiotics. You see almost 100% resistance to cefuroxime, cefixime, and almost 100% or 90% resistance to ampicillin and amoxicillin. The major concern here is that when you have carbapenem resistance, you tend to follow or you tend to rely on colistin as the antibiotic of choice. And this is more important. This is the concern that even we have bacteria which are resistant to colistin. The chart is not touching 100. What do we do now? This is the primary concern. And when you discuss how we weigh against international results, we see that WHO et al., in 2019, they looked at the evaluating risk factors to imipenem resistance, and they saw that patients who were greater than 60 years old and had a more hospital stay in ICUs as compared to wards, they were more predisposed to developing carbapenem resistance infections. And that is similarly what we had. Our patients who were greater than 60 years old in GA versus GB, we had more patients in GA as compared to GB with a p-value of less than 0.05. And then you have Tennant and his colleagues who reported in 2005 that culture isolates who were more, culture isolates of sputum and blood were more prognostic of carbapenem resistance as compared to urine, and that is technically what we report as well. Our patients who had carbapenem resistance had more cultures in blood and tracheal aspirate as compared to urine. And then looking at the burden of carbapenem resistance, Stevenson and his colleagues reported a greater mortality in resistance versus sensitive cohort. Technically, what we were showing as well, 35% versus 20% was their finding, and we reported 39% versus 21%. In terms of resistance, greater stay in the hospital alluded to greater mortality, and that is technically what we had. Patients who had a stay of greater than 10 days, there were patients who had 20 in GA and 3 in GB with a p-value of 0.008. Now, economic burden is very important, and that is because of the fact that in Pakistan, we are looking at out-of-pocket expenditures. We do not have state-sponsored healthcare system, although the government of Khyber Pakhtunkhwa should be credited here for starting health state-sponsored healthcare system for all their residents. And so when you see the economic burden resistance of carbapenems have, you look at Jude and his colleagues who reported that with meropenem resistance, you have hospital costs going up to more than 1.42 times. And then Zen and his colleagues reported that when you have carbapenem resistance, you have hospital costs going up by more than 1.5 times. And in terms of real numbers, in this Chinese hospital, this showed that their medical bills in 1 year of patients who had carbapenem-sensitive organisms were $11,755 as compared to resistant organisms in patients who had a total medical bill in 1 year of $22,962 with a p-value of less than 0.05. And that is because of broader spectrum antibiotics and longer hospital stays. Limitation of the study is because it's single center study, we have retrospective cohort. This is preliminary data, smaller sample size, requires multivariate regression to just focus on which is the most prevalent factor alluding to carbapenem resistance and thinking of poor outcomes. The takeaway is pretty much similar to what my colleague referred to earlier, is the judicious use of antibiotics, making sure that not only the senior leadership sitting here, but this knowledge is trickled down to the junior section, the junior colleagues, the students, as to make sure that antibiotic is not the solution to every problem and should be taken away judiciously. And as my colleague mentioned earlier as well, the free flow of antibiotic networking should not be done. Over-the-counter prescription of antibiotics should be stopped. And patients should be taking a prescription to the pharmacy where they could be given a antibiotic, and over-the-counter should be stopped. And the third thing, which my colleague has also mentioned before, is that we are in a race. We are in a race with the bacteria, and believe you me, they're catching up. If we do not catch up as clinicians, as researchers, as biologists, the bacteria will take over. And we saw in the results earlier that colistin resistance is there as well. So once we have resistance against colistin as well, where do we stand then? It's very important that we stay ahead of the war against the bacteria and focus on how our research is more clinically oriented to forming meaningful antibiotics. Thank you very much. Is there any question I'd like to have in the end? Thank you.
Thank you so much, Mayor Ibrahim Sajid. With this, our presentations for the first scientific sessions come up to an end. The art and science of asking questions is the source of all knowledge. The way you become world class is by asking questions. So the house is open for questions. Few of them, if anyone want to ask some question from our speakers. 3 questions. Okay. No one? Oh. Mir Sajid Ibrahim. Ibrahim Sajid. Is the question okay? Anyone else? Okay. जी सर जी सर जी सर जी सर श्योर
उसे कौन देख सकता कि ये गाना है वो यकता उसे कौन देख सकता कि ये गाना है वो यकता जो दुई की बू भी होती कहीं 2-4 होता
थैंक यू सर
और एक और है इसी सब्जेक्ट पर है कतरा अपना भी हकीकत में है दरिया लेकिन हमको तकलीद तुनक ज़र्फ़ी मंसूर नहीं तो गॉड इज विद इन
Thank you, sir. I guess this weather and the stars and the mountains, they all...
Just one
Okay, sir.
single. We are running short of time. We are already late by an hour. So the tea break has been suspended. Those who want to tea is served. So we will right away start with the next session. We'll right away start with the next session, and without making any noise, you can have your tea from the back, say, it's served over there.
Okay, sir. Okay, sir. Okay, sir. So we all are lucky to have the poetic insight of our brainy medical fraternity. So I would like to request my chairpersons of today's session to have some reviews about our speakers and our presentations of today. Professor Qazi Masood, Professor Azizur Rahman, and Professor Talat. Only one? Okay, sir.
I have been given the honor by my colleagues to give the summary to save some time. And first of all, Bilqis Shabir, the talk XDR typhoid, and I think she very rightly emphasized the important point that this lousy test called typhidot should not be done. Actually, many laboratories have already abandoned, and please do not have this test, and if it is done, do not give it any weight. It is more confusing than any of any help. The second talk by Dr. Abdul Khalik, very, very good talk, and I think he also very rightly emphasized, and I'm going to emphasize the same statement: do not do what does not work. I think that is the main message from his talk. Do only what works. And from Dr. Suhail Khan Raja's tuberculosis. And I think my summary of that talk is this XDR-TB is very serious business. And I think for a busy general practitioner and even for physician, it is hard to be well aware of all these new developments. So I think we should develop a habit that all those cases should be referred to the specialist and they should be treated in a specialized center. And my most important comment is our last speaker. For those senior fellows who are losing hope from the younger generation, this is a ray of hope for them. Such a brilliant talk and original work. And I must compliment the parents who are sitting here, Professor Sajid and Dr. Samira, very well groomed, and Ibrahim, very well done. I can see a great clinician in future. Thank you very much, everybody.
Thank you, sir. I would like to extend my thanks to the distinguished chief guests and to the chairpersons and our speakers of the day and our audience as well. Moving on to next session on hepatology, I would like to have Dr. Mehreen Zaman on stage as a stage secretary. Dr. Mehreen Zaman, please.
Assalamu alaikum and good. I would like to start my session by introducing myself. My name is Dr. Mehreen Zaman, and I'm working as an assistant professor in gastroenterology and hepatology at Allama Iqbal Medical College. I would like to start my session by inviting our worthy panelists. Our first panelist is Professor Dr. Muzzafar Sheikh. He's a professor of medicine at Liaquat University of Medical and Health Sciences. Professor Dr. Muzzafar Sheikh. He's not here? Okay. Our second panelist is Dr. Muhammad Salim Khan. He's the Chief Consultant Physician at the DHK Hospital at Kotli Azad, Jammu and Kashmir. He is also an MRCP UK PACES examiner and a member of ACG, EASL and BSG. Dr. Muhammad Salim Khan. Our next panelist is Professor Dr. Munir Azhar. He has served as the Professor of Medicine at Quaid-e-Azam Medical College, Bahawalpur. Professor Dr. Munir Azhar. Our first talk is by Professor Dr. Muhammad Arif Nadeem. He's a professor of medicine and gastroenterology at Services Institute of Medical Sciences and Services Hospital, Lahore, and he's going to talk on hepatitis C updates. Professor Dr. Muhammad Arif Nadeem.
Assalamu alaikum. Bismillahirrahmanirrahim. Thank you, PSIM, Professor Aftab, Professor Tariq Wasim Sahab, for allowing me to talk in front of this August gathering today about the hepatitis C. I have adopted this presentation from the Pakistan.
Can I have 5-minute break?
Okay.
Since I would request those who are taking tea that we give a 5-minute break, just quick enough, and don't make any croaky noises, and we'll be starting with the proceeding because it was disturbing. So 5-minute break for the tea, and just without making a noise, you back onto your seats kindly. Thank you. Without permission.
Just a very small request for all of you, if you can bring your tea to the hall and you can, have a working tea along the side of the session because we are really late. and we are very short of time. So I would request all the participants and attendees to please bring their tea to the hall, and they can have a working tea along with the session.
I would like to invite Professor Judabedullah to chair this session.
All the audience is kindly requested to take their seats now, please. So we can start with the session. It's a Jummah today, and everybody has to go and offer their Jummah prayers. All the audience is kindly requested to please take your seats so that we can start with the presentations. Professor Arif Nadeem is yielding to start. Please be back on the seats, please. आ जाएं वापस. थैंक यू. बहुत चाय मिलेगी सारा दिन आज. Tariq Wasim Saab, being the chairman of the organizing committee, has decided that there will be a tea break after the lunch so that you can have another cup of tea. Please be back on your seats. आए जी आए, ये लाइट बंद करें ताकि मैं देख सकूं लोगों को. आए तशरीफ लाएं वापस. चाहे बाहर भी है, बाहर लॉबी में ये जो स्टॉल्स लगे हुए हैं, मैं खुद इधर चक्कर लगाता हूं. बच्चों, बी बैक ऑन द सीट्स नाउ. आए जी आरिफ नदीम साहब, लेट्स स्टार्ट. मैरीन, शुरू कराओ.
I would like to invite Professor Dr. Arif Nadeem once again for his talk on hepatitis C updates. Professor Dr. Muhammad Arif Nadeem.
Bismillah. I adopted this presentation from the guideline of Pakistan Society of Hepatology, EASL and WASLD. As you know, morbidity and mortality attributes to hepatitis C virus infection is on the rise in Pakistan as well. Worldwide, approximately 160 to 180 million people are suffering from it, out of which 7 lakh die each year because of inbuilt or associated complication like cirrhosis, hepatocellular carcinoma, and liver failure. In Pakistan, about 4.9 or 5% of Pakistan population suffering from it, which makes roughly 11 million people today. And 90% of them are suffering from hepatitis C virus genotype 3. True prevalence cannot be detected because there are missing persons which are not coming for the investigation or screening. We have to look for them. We have to try them to bring into the treatment center for their diagnosis and management so that we can prevent the further progress or of the prevalence and the communication of this disease to others. And we can prevent it if we have effective treatment provided to them at their doorstep or at least nearby their center. As you know, HCV antibody is the primary test which should be done by ELISA to pick the patient having this disease. The screening tests are not certainly not true picture of diagnosis in these patients. Once we know the patient has positive, then we have to treat as early as possible if there is no contraindication to its treatment. If patient is not positive, at least once within 6 months, the test should be repeated so that we double sure that he or she is truly not positive. And if it is not detected and patient has some tendency to acquire it or it is more vulnerable to that, then this patient should be followed up and additional testing can be done. And for junior colleagues, the interpretation of these tests could be if somebody has got anti-HCV antibody positive, but PCR is negative. So he is supposedly having spontaneous recovery of HCV, but it should again be confirmed within 6 months. If somebody has antibody test negative, but PCR is positive, then patient is possibly having acute hepatitis C. If patient has recent source of transmission, which we can identify if we are able to, or has developed recent onset of jaundice, or his ALT has increased by more than 10 times upper limit normal, or patient has appearance of anti-HCV within following 2 months period. This patient is patient of acute hepatitis C. If somebody has got both PCR and anti-HCV antibody positive, then he is certainly having chronic infection with hepatitis C, and he or she should be treated if there is no contraindication. This table is very important to decide the state of the liver, whether patient has got fibrosis, cirrhosis, or what could be the possible survival time for initiating the choice of the antiviral drug which can we offer to this patient. Natural history, it is still not clear, highly variable. Chronic infection can be accompanied by extrahepatic manifestation like mixed cryoglobulinemia, renal diseases, hypertension, type 2 diabetes mellitus, lichen planus, and even lymphoproliferative disorders. And there, usually we see the patient which comes commonly with non-specific symptoms like fatigue, nausea, abdominal pain, weight loss. And once patient has acquired this disease, there is rapid progression of hepatic fibrosis and associated cirrhosis and later on its complication. So we have to treat the patient to avoid the progress of fibrosis, give early treatment, and prevent the complication associated with the cirrhosis of liver. Who should be treated? The long list of indication, and there are also some contraindication as well. The patient who has got fibrosis or cirrhosis, if somebody has got extrahepatic manifestation, if somebody has recurrence after having been transplanted liver, a patient who is at risk of getting HCV because of its socioeconomic or social habits, and the patient who has recombinant cirrhosis and it has indication for liver transplant, then if patient has got score of more than 18, then he should be treated after liver transplant. But the score is less than 18, then we can treat it before the transplant and the patient who has got limited life expectancy, then we we can reserve our offering to the treatment for this patient. Their contraindication, there is some gene resistance testing which is not being tested in Pakistan, इसलिए हम वो check नहीं कर सकते. Other patient who has got child B or child C in decompensated cirrhosis, or if somebody has got chronic kidney disease with GFR less than 30 ml, उसमें भी ध्यान से treatment देनी चाहिए. Primary goal is to get SVR. If somebody is getting treatment for 12 weeks, then 12-week SVR. If somebody is getting 24-week treatment, then 24-week SVR is the main primary goal of our treatment. Because if we have attained that SVR, then we can rest assured the patient that the chance of complication or morbidity or mortality to him will be at par with general population, because SVR has assured us that whenever we achieve SVR, the mortality morbidity is as with the other general population. The drugs which are available in Pakistan are these drugs, and we can use them according to indication, we think. And this is dosage. How to assess for treatment? This is the protocol which we have adopted from the rest of the world, that patient should be first assessed for the fibrosis or disease status of the liver. For FIB-4 score, EPRI score, and even we can do the fibroscan for stiffness or fibrosis of the liver. And we have to know whether the patient is already having cirrhosis or not, liver nodularity or splenomegaly on the ultrasound, presence of ascites or platelet count is less than 100. Or somebody has previously liver biopsy done and he is knowing the status of the cirrhosis or not. But before doing the treatment, we have to know which other drugs patient is taking, because there are some drug interactions. The drugs may be having increased in the progression of the disease, or the disease that is he or she is suffering from may potentiate the cirrhosis or its complication. First, we have to know which drugs he or she is taking, so that we can judge whether that disease is under control or not. Similarly, we have to make sure that we know the drug interaction which we are drug prescribing with the other drug patient is taking. The test which we have to do is blood complete, serum albumin, bilirubin, ALT, AST. We have to check the EGFR so that we can know patient is having CKD or not. And also we have to know the status of the pregnancy in female patient, because pregnancy, if it is there, then we have to wait for pregnancy to be over. Afterward, we have to treat. Otherwise, if somebody is planning for pregnancy, patient should get treatment first, then she should plan for pregnancy. The other test we are required is HBS antigen. If patient is negative, then we have to give vaccination. And we also want to know the HIV status, and also we have to know the presence of HCV RNA in that patient. These are the diseases which could be associated with that patient. We have to know whether the patient is suffering from chronic kidney disease, ischemic heart disease, diabetes mellitus. There are some patients who are not fit for simplified treatment, which I will describe later on. These are those requiring the specialized modified regime according to the status they have already with them. This could be prior hepatitis C treatment. Patient may be having cirrhosis. Patient may be having HIV or HBS antigen positive. Patient may be having pregnancy. We have to wait for that. If somebody has got HCC, then depending upon the MELD score, whether it is required transplant first or treatment first. And if somebody has acquired an infection after transplant, those who are eligible, the drug which is available in Pakistan is a combination of phosphate with vilpetasfer, which should be given for 12 weeks. The other combination is not available in Pakistan. In type 2, this is the combination which we use for 3 as well. Some patient who is having cirrhosis, whether patient has got treatment or not treatment beforehand, if he has already developed CLD or has gone under treatment for hepatitis C or has developed end-stage renal disease or has HIV, HBS antigen or is pregnant, then simplified treatment cannot be offered to these patients as well. If somebody has compensated cirrhosis, then we have to know which child class he or she is suffering from. Liver biopsy is now not required. We can test it with the non-invasive method. As I've already mentioned, we can do elastography, we can do the fibro scan, and then we can do even, we know the APRIC score, or we can do ultrasound to pick the nodularity in the liver, or if somebody has got platelet count less than 100,000, then we can offer this kind of treatment to type 3 genotypes, in which again, phosphor with vilpetasvir, with or without ribavirin, depending dose, ये हम use करते हैं आजकल वैसे, for 6 months at least. लेकिन जो नई ड्रग्स हैं सफाफर विल्पेटास्फर वो 12 वीक तक भी दे सकते हैं. Which treatment monitoring should be offered to these patients on when patient is taking medicine? For this purpose, we have to make sure that patient is with us. He is following all the instructions. These drugs may cause hypoglycemia. We have to check it. And also because of drug interaction, the anticoagulant drug, if somebody is taking, we have to make sure that INR should monitor. And also continuously, we should keep on monitoring the liver injury, because if somebody has tendency of cirrhosis, even if his fibrosis is not more than 2, even then patient can enter into the advanced or rapid liver injury. We have to check these things frequently while patient is on treatment. SVR, again SVR, is week 12 SVR is required because this is the surety for us that patient has been treated. After follow-up, which is required after SVR, is if somebody has got normal liver injury, normal liver status before the treatment starting with these antiviral drugs, oral drugs, then no further follow-up is required concerning liver. If somebody has ongoing risk of HCV infection because of its habit, IV drug user, or male having sex with male, then patient should be continuously followed, have repeated advice for risk reductions, and followed biochemically for LFTs. And if somebody has developed cirrhosis, then the follow-up should be every 6 months with ultrasound, with or without alpha-fetoprotein. And if somebody has developed nodule or suspicion nodule, then we can offer the triphasic CT scan as well. If somebody had bled before, then surveillance endoscopy and follow-up treatment with bending is required. We have to ask the patient to avoid alcohol. If somebody has not developed SVR or has not responded to treatment, then if somebody is not getting treatment immediately, then follow-up will be for surveillance of the complication of the HCV-related liver diseases like LFT, any clinical sign of ascites or blood loss from gut, or even if patient has developed extra hepatic manifestation, we have to look for that. In these circumstances, if patient not getting treatment, then again surveillance with ultrasound with or without alpha-fetoprotein is required for early or rapid finding of the chances of HCC. And he and she also requested not to drink alcohol. Then if patient somebody has experienced treatment, then we can offer again phosphorus with vilpetasvir or phosphorus with vilpetasvir with voxeloprevir. ये भी available है, Vosvi के नाम के available है यहाँ पे. ऐसे पेशेंट में जो हम यूज करते हैं, जिनको पहले रिबाविरिन और इंटरफेरॉन मिल चुके हैं, उनमें हम लोग यूजली रिबाविरिन के साथ ऐड करते हैं वेट बेस्ड थेरेपी के मुताबिक. If somebody has HBV co-infection with HCV, how we follow? The following will be same as patient has got mono infection of HCV. But if patient is fulfilling the criteria for treatment of the HBV, then we have to offer him nucleotide analog for HBV infection as well. If patient has HBs positive and HCV, but HBV DNA is not detectable, then we have to give nucleotide analog prophylaxis for at least 12 weeks after the stoppage of therapy, because this patient can have chance of reactivation of HBV. So we have to take care of that as well. In patient who are HBs antigen negative, anti-HB and C antibody positive, and he is on anti-HCV therapy, we have to monitor it with ALT monthly, test HBs antigen and HB DNA if ALT level do not normalize or is on rise. And we have to then start with nucleotide analog for hepatitis B virus DNA treatment. If somebody is had treated with phosphor-based therapy, then for our Pakistan level, we have to give again offer phosphor with vilpatasfer and weight-based ribavirin, because the other drugs are which are recommended is ledipasavir and phosphor with ribavirin as well. These two regime are available in Pakistan. The next thing, because the time is short, I will just mention acute hepatitis C for now. If somebody has got acute hepatitis C, then the treatment which we can offer is same regime which we offer for the chronic hepatitis C,